Welcome to the UK Dementia and Palliative Care Conference 2026 podcast, brought to you by Rowcroft Hospice. Recorded at the beautiful Buckfast Abbey Conference Centre in Devon, this series explores the critical role of dementia and palliative care in supporting those living with dementia. Across these episodes, we'll be sharing expert insights, real-life experiences, and innovative approaches to improving care. Thanks for tuning in. Let's get started. Workshop 1. Palliative Care for People with Dementia, Uneasy Bedfellows. Facilitated by Prof Catherine Walshe, Professor of Palliative Care, International Observatory on End-of-Life Care, Division of Health Research at Lancaster University.
Thank you. No pressure. No pressure at all. So the title of today's conference is about dementia and palliative care. And I have been asked to talk about actually whether they are uneasy bedfellows. So the session that we've got now, I stand between you and your next coffee break, is actually a workshop. So what's going to be happening is I'm going to do some scene setting. So you're going to just have to put up with me talking for about 15 or 20 minutes. But then I've got a job or jobs for you to do. So I'm going to ask you to get into smallish groups and we're going to have some discussion and then a little bit of feedback. So, but hopefully that will become clear and then we'll come back together for just about 5 minutes before coffee. So, first of all, greetings from Lancaster University, where I work at the International Observatory on End-of-Life Care. And as part of my role there, I'm involved in a number of studies, including those working with Jenny van der Steen as well, looking at the intersect between dementia and palliative care. I'm not particularly going to talk about those studies. I knew some of them would already be mentioned. I'm going to talk much more broadly to set the scene about why people with dementia don't necessarily get palliative care. So here's my question. Why do people with dementia still die without palliative care? And I'm sure for those of you in this room who look after people with dementia and look after them towards the end of their life, you will hopefully, well, perhaps you do work in a perfect utopia, but most of the people I've spoken to while we've been here today recognise that that is not always happening or sometimes rarely happening for people with dementia. So I want to introduce you first to my fictional character, but I think you will all be familiar with people like her. Let's call her Joan. She's probably in her mid to late 80s, typically. And let's say she's moved into a nursing care home perhaps about 6 months to a year ago. Husband might still be alive, but he may well be struggling to provide care, hence the move into a nursing care home as Joan has deteriorated. So she's in the nursing care home. And she's actually had a couple of admissions to hospital within the last 6 months. Perhaps she's had a respiratory tract infection, a urinary tract infection, possibly a fall. One of those at least resulted in the ambulance being called out to the care home in the middle of the night and they took her into hospital. I think you'll all agree that is a not uncommon scenario for people with advanced dementia. So we know then that Joan is likely to be towards the end of her life. I've already described things happening to Joan or alongside Joan that would probably indicate that she has palliative care needs. But is Joan getting palliative care? I think for most of the Joans of this world, certainly where I live, the answer is probably no. And certainly not when we're talking about specialist palliative care. So my challenge to you is to hold the Joans of this world in your head while we're talking about some of the facts and figures so that you can think about how we could do better. So let's start off with a couple of facts and figures. Now, we heard a lot of facts and figures this morning from Jeremy about incidence and prevalence, but my children are always telling me, you're always about death and dying, Mum. So let's have some death and dying figures. So in the UK, and these were the latest data that I could find, the 2025 data can't be out, but dementia was the UK's leading cause of death. That is quite a change, and I'll show you that in a moment. Now, to be fair, as you can see at the bottom there, they have not clustered everybody with cancer together. That's just lung cancer down at the bottom. But nevertheless, dementia has overtaken many other causes of death in the UK. So forget that at your peril. And in fact, the other data that they showed here was actually dementia is that sort of goldy orange line, the only line that's going up. So currently at the moment, and you can see from the data that we saw this morning, this trend is likely to continue, at least for the foreseeable future. While deaths from lung cancer are relatively constant, deaths from other causes are perhaps slightly declining, deaths from or with dementia are going up. So if, as palliative care providers, we are not thinking dementia, we are not thinking about the populations that are going to need our care now and in the future. Sometimes when I'm talking to people, they say, well, yeah, fine. Yes, we know our residents, for example, in the care home with dementia are going to die. Of course they do. They're caring for dying people. But they're not always thinking about palliative care and palliative care needs. So one of the questions people say is, well, do they actually have palliative care needs? So here, let's turn to a study conducted by some of my colleagues, not at Lancaster University, but we do work together, thinking about the palliative care needs of people with dementia. And I guess it's no great surprise to you for me to show you the data that actually, of course, people with dementia have palliative care needs. And just like people with a whole host of other conditions, the need for palliative care increases the closer somebody is to death. And you can see that line going up in the last weeks and months of life. Now, the reason that's challenging for some of us, we will go into in a moment. But just again, hold on to the fact that those people who are dying with and from dementia very definitely have palliative care needs. And whilst this particular study showed that it went up to, I think it's about 30 or 35% there, when you think of the sheer number of people who have dementia, that's one heck of a lot of people with palliative care needs who have dementia. So why aren't they getting palliative care? So this is my illustration of the challenge of getting palliative care if you have advanced dementia. There are a number of obstacles in the way, and the path is not straightforward. Now, I actually think we can do something about that. But let's look for a moment about why those obstacles are there and why the path is actually so tortuous to navigate for people with dementia, those providing care, and their friends and family. So I've actually come up with a number of different reasons why that path is so challenging for people with dementia. So the first reason I've come up with is actually about prognostic uncertainty. Now, as a clinician, and of those of you who are clinicians in the room, you'll know that prognostication for virtually any disease is a highly inexact science. We get it wrong probably as often as we get it right. But actually, for people with dementia, that prognostic uncertainty is even greater. When you look at some of the data about time to death for people with dementia, it's hugely variable, and it's variable by years. But also, and as this quote from this particular study shows, that actually we are perhaps even more reluctant to discuss prognosis with people with dementia and their families. It's a hard conversation for any clinician, irrespective of diagnosis. It appears to be even harder when you're talking about people with dementia. So when you think about that slide that I showed about palliative care needs increasing in the months before death, it's easy to tell when we know the date of death and we can work backwards. But we don't care for people in the backwards. We care for people in the forwards. And actually, when you're faced with caring for somebody with dementia, it's really difficult to think, how long do they have left? But my challenge to you is it's not that difficult to think about what their needs are and their presenting needs at that point in time. So that's challenge 1. Challenge 2 is a history lesson. And I think as working in specialist palliative care, which is my professional background, we have a historical bias. Now, I worked in palliative care back in the 90s and noughties when we spent a lot of time collecting minimum data set. It doesn't really happen anymore, but I've taken us on a little historical journey back to 2010 and 2012, but it's 2012, I think, those data. Now, certainly when I worked as a community Macmillan nurse, I don't think I ever looked after somebody with dementia. Or if they did have dementia, it was because they were referred to me because they also had cancer, to be honest. It wasn't because of the dementia diagnosis. And so if we look at those data from, 10 to 15 years ago now, we'll see that the vast majority of people referred to specialist palliative care had cancer. And that's because here in the UK, not the same in every country, historically, palliative care services grew up with a focus on cancer. I came from a cancer background. Most of my colleagues came from a cancer background. We didn't necessarily have the skills to care for people with other diagnoses. Now, that is shifting and changing. Obviously, I'll acknowledge that. But certainly, if you looked at the data again from that same year, even of those who did not have cancer, less than 10% of that tiny proportion actually had dementia. So we're building that from a really tiny base. And although I'm talking about data from 15 years ago, we are sluggish, I think, sometimes in care and in thinking about care processes. So we've got this historical bias that we need to break through. My third challenge is of service fragmentation. Now, I think we all acknowledge that services here in the UK are not fragmented, but there's a specific and particular point that I want to make to you. So we think about the care for people with dementia, and it's typically, not always, but it's typically provided over a long period of time. And so long-term care models, particularly social care models, predominate. Now, I'm not saying we're always doing a great job at it, but we have a particular way of providing care to people with dementia that's predicated primarily on a long-term care model. That's not how we provide palliative care, though, is it? This is some data from hospice services where the median time for referral to the hospice to death was 48 days. That is not a long-term care model. That's a very short-term care model, but it also demonstrates our episodic nature of care. For those who are in the system for longer, they're often referred, discharged, referred, discharged. And in fact, we are often encouraged to discharge people from specialist palliative care services. Completely different forms of care models. And there's a real conceptual and cultural difference, I think, between those care models that we often struggle to actually work together because we don't always quite understand the care model that somebody else is coming from. Or even if we understand it, there's a fracturing there between the way that we provide care. My next challenge is one of language and terminology. And I think this has been referred to by some of our other speakers. So in this, the question in this study was knowledge of dementia. Do family members understand dementia as a terminal condition? And I think I can answer that with a single word. And I think you know what that single word is, which is no. People do not understand dementia as a terminal condition. They understand it as a lifelong condition, for sure. Of course they do. They understand it as a condition from which somebody is sadly going to deteriorate. But do they understand it as a terminal condition? No, they do not. Do they understand what palliative care means? Clearly not, because Jenny's just told us that. That's the main question that people wanted to know. What is palliative care? And to be fair, it's also a question that people with other diseases ask as well. So this is a fairly well-known study about renaming palliative care to supportive care. Personally, I don't think it makes a difference because whatever you call it, people will react to that in a particular way. So they're just some of the challenges we face. And I think, though, from the data that we've seen already today, we need to do something about those challenges now. Not tomorrow. It was a pity we didn't do it yesterday, but we can certainly do something about it now. And if we look at the latest data about palliative care and the need for palliative care, the predictions clearly are only going in one direction. So this is modelling forwards in terms of the need for palliative care. So I hope what I've done a little bit there is set out a bit of a stall about the reasons for some of the challenges that we have. But I'm posing you a question now, which is, what does good look like? We cannot alter the past, but we can make the future different. I'm not saying that's easy. We work, in some really complex, under-resourced settings. But I think we can think about what we can do attitudinally, culturally, and sometimes with a little bit of money behind us to actually make a difference for people with dementia. So we're going to go on now, and I'm going to make you do some of the thinking and some of the work, because it is a workshop, so I'm going to make you work as well. I've done my 20 minutes of scene setting. So I'm going to ask two questions, first of all. So who of those in the room would primarily say that they work in palliative care with an interest in dementia? Put your hands up. Okay. And which of you would say that you work primarily in dementia care with an interest in palliative care? Okay, so slightly more of the latter. So what I want you to do, and the room isn't really set up for that, so we're just going to have to upset people by moving the chairs. I guess as long as we move them back again, that's going to be okay. But I want to get you in groups of people who work in similar settings to yourselves. And I've asked you basically to talk about the same question, but from some different perspectives. So if you work in palliative care or primarily in palliative care, I want you to get together in groups of about 3, 4, 5, something like that, and talk about what are the challenges of providing care in your setting. That might be the hospice, it might be in the NHS, it might be in the community for somebody with dementia. And I want you to talk about those challenges, but when we come back together to provide some very brief feedback, I only want you to feedback the answer to the question at the bottom. What could we do differently tomorrow? So that's not going to cost any money unless you happen to have a couple of million down your back pocket that you can suddenly spend. But it's about what we could do differently tomorrow. And equally, for most of you who work in dementia care, I want you to talk about it from the other perspective. What are the challenges of providing palliative care in your setting? But with the same question that we're going to come back with, what could we do differently tomorrow? So we've got about 15 minutes for that discussion to give us some time to just come back together again, to actually do a little bit of feeding back, and then just a little bit of time together before we have coffee. So if you work primarily in dementia care and you're going to be answering the green questions, come into groups on this side of the room. And if you're going to be and work primarily in palliative care and in the orange side of the room, on that side in small groups. And if you're not either of those, just choose wherever you're going to sit, because that's absolutely fine. But I'm making you all do some work. Okay, time's up. Let's get some feedback then for what people say that we could do tomorrow. So I'm going to go in random order. So, and I told everyone only one sentence, because otherwise it's going to take us too long to get round the room. It doesn't matter if your sentence is the same as somebody else's. That's actually quite interesting, because we've been having the same, potentially same discussions. So if I go to the back of the room on my right-hand side, what's your single sentence from that group there? So the one word, communication. Brilliant. Okay, let's go to the back on the left-hand side. What's your sentence? Single point of contact. Yeah. Also, yeah, I can see one again. That's also related to communication. Right, let's come to the front here on my right-hand side. Develop a national specialist dementia palliative care service. Okay, tomorrow. Okay. Fair enough. Right, to stop you running around, let's go to the middle group there.
Yes, we need collaborative working to standardise the pathway and to prioritise who and when palliative care is initiated, and not let's forget to factor in local government reorganisation, which is happening in the next few years, and that will play a factor in it.
Okay, you crammed a lot into that sentence. Well done, well done. Multiple clauses. I think there's one more group on this side. I was trying to get you to stop running around there.
We've got inpatient and community teams here, so quite broad. So we said early identification of palliative care needs, proactive community outreach to those who need it most, and promotion of continuity of care between primary and secondary care services.
Perfect. And then I think there's a group just in the middle there as well.
We all agreed that we should start some sort of campaign called Building Bridges, where the people who work in palliative care work alongside people who work in the dementia world, and bring the two together. We should get people with dementia and their carers talking to people who work in palliative care, so we can bring the two together as one and then take it forward from there.
So I'm hearing communication, collaboration, coordination. I've got 3 C's already. Now you're going to have to run around here. So should we go to the groups on this side? What were your single sentences of what we can do tomorrow?
Advanced care planning discussions to involve specifically what unmet needs and distress look like in dementia to plan ahead. And as a sort of an offshoot of that, to expand our battery of anticipatory medicines to include, where appropriate, antipsychotics like risperidone, olanzapine, etc., to manage that if we need to.
It's amazing what people can cram into a sentence without breathing. Okay, so we've got some medication and advanced care planning. What's the next group back?
I think we said there's best practice demonstrated in Sidmouth with tremendous involvement of volunteer community working alongside the hospice for people living with dementia in the community. And the second thing I think we concluded was improved ensuring the customer voice, the patient voice, is in the care plan, the advanced care plan. It's very easy for it to become very medical. We heard from the online interviews today the importance of their individuality.
Brilliant, thank you. And then I think we've just got 2 groups in the middle.
Through knowledge and skills development, change the culture and understanding of dementia as a primary diagnosis.
Brilliant. And then I think, have we just got one more group?
We talked about altering services, our services, to fit the person's needs rather than expect them to move to the correct environment or have to speak to different people. It's actually connecting and bringing it to them.
Right. Is there any group that hasn't said anything yet?
Just off the back of something that Norm said, that there are organisations and resources out there that combine the two, and shameless plug, for Hospice UK, we have a community of practice that puts people who work in dementia care alongside people who work in palliative care to share their stories and experiences.
So some of you were quite ambitious in terms of what you want to do tomorrow. Okay, I'll give you that, because the world wasn't changed in a day. But I think we've all heard things that we could do that would probably make a difference, that are not going to cost lots of money, and actually are much more about attitudinal and cultural changes and enabling coordination and communication. And I think that is within all of our gift to do something about that. I'm just going to take the last few minutes just to talk a little bit about research in this area, because I am a researcher, so I'm going to talk to you about research, because sometimes the things that we talk about, we do actually need to study and understand a little bit more. And I just want to highlight, for those of you that might not have seen it, the relatively hot off the press research priorities for palliative and end-of-life care, which were done under the auspices of the James Lind Alliance, together with Marie Curie, and they launched them in the autumn last year. So it felt like the autumn. Anyway, it was relatively recently. Now, this was a refresh of the priorities that they worked on perhaps 10 or 15 years ago, something like that. Doesn't feel like 10 years, but it probably was. And there's been quite a shift in the priorities. And I wanted to highlight the number one priority, because what has now been highlighted as the number one priority for research in palliative and end-of-life care: dementia, and the care of people with dementia. So that has now been recognised as a national priority. Now, I know many of you in the room may well not be researchers, but I think we can all be part of research and part of enabling the care that we give to people with dementia to be as evidence-based as possible. So this is really just a final plea in the last few seconds between me and coffee to really emphasise the importance of research. Because sometimes what we think is a great idea, I referenced the Liverpool Care Pathway in palliative care, turns out perhaps to be not the best idea, or indeed to be implemented without sufficient evidence of effect. So I think we have some fantastic ideas here, but as Jenny highlighted in her talk earlier, sometimes the things that people say when we ask them are not necessarily what we as professionals think they're going to say. And so the only way of doing that is actually to ask them, and to, as a researcher, I'm going to say that's research. So I'm going to finish with a shameless plug for actually being an expert in research, because I don't expect you all to go off and suddenly do research. You can, if you want, this is the shameless plug, do a PhD in palliative care with me and my colleagues. I'm not expecting you're all going to go off and rush and do a PhD. But it is just a final plea that research is a skill as much as your clinical skills are skills. So partner with your local researchers, because I don't work clinically anymore. My great research ideas come from the clinicians and practitioners that I work with who come to me with great questions. You go to your research colleagues with great questions, and they'll thank you for it. Thank you.
That's it for this episode of the UK Dementia and Palliative Care Conference 2026 podcast. A huge thank you to our headline sponsor, Audley, event sponsor, Wallens, and to Dementia UK for their invaluable support. This series is recorded and produced by iNarrator and proudly hosted by Rowcroft Hospice. Links to resources mentioned are available in the show notes. If you found this discussion valuable, please share it and stay tuned for more thought-provoking conversations. Until next time, take care.